Good evening, everyone, and welcome to today's webinar, Natural Approaches to Cardiovascular Health. My name is Max Langhurst, and I am a functional medicine consultant at QOL Labs, and I'll be your moderator for today's webinar. QOL Labs' mission as a company is to provide products supported by human clinical studies to practitioners and their patients. I have everyone on mute to avoid background noise. However, your participation is important to us. You'll have the opportunity to submit questions by typing them into the Q&A section of the control panel located at the bottom of your screen. And you can do this at any time during the presentation. I'd now like to introduce today's speaker, Dr. Barry Sunshine. Dr. Barry Sunshine is a Board Qualified Applied Kinesiologist, Chiropractic Orthopedist, and Chiropractic Rehabilitation Specialist, and a certified Thermographer. He has 25 years of professional practice and study, and he lectures and teaches his techniques to healthcare professionals through the Sunshine Integrative Health System. I will now pass this webinar to our speaker, Dr. Sunshine. Please begin.
Hello, everyone. I'm glad to have you. We're going to talk about cardiovascular health, which is a very important subject in this day and age. The objectives of the webinar are to give you an understanding of lipid transport and metabolism. We're going to review the pathogenesis of atherosclerosis. We're going to review endothelial dysfunction and how it plays a part in atherosclerosis. And then you're going to learn natural approaches to normalizing blood pressure. So, heart disease is the % killer. This is statistics from 2012 from the CDC. Heart disease is number one, 23.6% of the people, about a quarter of the people in 2012 died from heart attacks. Cancer is the second one, and then you can look down through there. But heart disease is the number one killer. It, like cancer and diabetes, could be reduced if people would change their lifestyle, change what they eat, what they do. It could be reduced by 80% heart disease, 60% cancer, and diabetes 90%. But there's 27 million diabetics, 1 in every 3 by the year 2050, or 100 million. Those statistics are staggering. United States health is not what it should be and can be. The thing that really surprised me, there's been an increase of 35% in strokes in children under the age of 20. So what is cardiovascular disease? Well, cardiovascular disease is a chronic disease that is an inflammatory process. It was studied in the Framingham Heart Study, which is probably the most well-known study on heart disease, which was started in 1948 with approximately 5,200 men and women. They were given lifestyle questionnaires and physical exam and blood tests. They were enrolled. The second enrollment was in 1971, the second generation men and women, again, 5,100. And then in 1994 and 2002, the third generation. So this is a long study. This is the time-honored study. What they found, the risk factors for heart disease were high blood pressure, high cholesterol, smoking, obesity, diabetes, and physical inactivity. So these were the risk factors that they found for people for heart disease. The Bogalusa Health Study, or heart study, it's not very well known, but it's very interesting, I find. It was 16,000 children that were followed over 30 years, starting in 1973. Same type of thing: physical examination, blood tests, dietary records, tobacco use, all of those things done yearly. When these children, or in some early young adults, died from accidents or unexpectedly, not from illness, they autopsied them. And the autopsies found that as early as 3 years of age, there were fatty streaks in the aortas of the children. Starting in the second decade, there were fatty infiltration in the coronary arteries. Now, this was consistent with what was found in autopsies of Vietnam and Korean War soldiers on the battlefield. What they found was that heart disease starts very early and progresses until maybe the cause of death. So what is atherosclerosis? It's a chronic inflammatory disease of the arterial wall. Plaques in the arterial wall can decrease the size of the lumen and can cause occlusive arterial disease. So here's an artery. The left side you can see is a normal artery, and then you see mild atherosclerosis and then severe atherosclerosis. And the yellow, if you have color, the yellow is basically cholesterol. And so cholesterol is a part of the process of atherosclerosis. It does a lot of other things. So cholesterol is a steroid molecule, and this is a steroid molecule. This is cholesterol. It is produced in the body, and it is utilized by the body in every cell of your body. Cholesterol can be made into steroid hormones such as progesterone, aldosterone, cortisol, testosterone, estrogen, the 3 estrogens. They all come from cholesterol. Vitamin D comes from cholesterol. Every cell membrane in your body has cholesterol. So cholesterol is a good thing. It's been given a bad rap because of what happens to it in the arteries. Stress is one of the biggest things that is involved with something called the metabolic syndrome, which is clinically a number of different conditions that will lead to heart disease. So what is stress? Stress is what are stressors? Let's put it that way. If you see in the top left, there's ME, that's mental emotional stressors, chemical stressors, dietary stressors, physical stressors, electromagnetic, microbial. They stimulate the hypothalamus. The hypothalamus in turn stimulates the pituitary, and the pituitary stimulates the adrenal to produce cortisol and adrenaline. Now, if you remember the risk factors, if you look at what cortisol does, notice that it increases cholesterol. It affects the production, it increases sugar in the body, which then will cause insulin to go up, and insulin in turn will cause cholesterol to go up. If you look at the other side, you see adrenaline stimulates blood pressure, increase in blood pressure, and also glucose and glucagon, which increase sugar. So diabetes, insulin resistance are all linked up with heart disease, and they're all linked to stress. Here's another depiction of it. Cortisol suppresses secretory IgA, which is the immune system. It decreases thyroid function, which then can stimulate heart problems. On the other side, it can stimulate insulin resistance, and insulin resistance can cause high blood pressure, cholesterol, or triglyceride. So insulin is necessary for us to live, but it also, in excess, creates problems. So let's talk about lipid transport. Lipids are not water soluble. They need to be packaged. They are packaged in something called lipoproteins. And the biggest one of these is a chylomicron. A chylomicron is the largest lipoprotein. It basically is a way of the body bringing fat and cholesterol from the intestine into the bloodstream via the lymph system. And once it gets in there, it will go around and later end up in the liver, where it's changed to what's called a very low density lipoprotein. This in turn is a way of bringing primarily triglycerides and some cholesterol and phospholipids to cells in the body. And as the triglycerides are removed, that very low density lipoprotein becomes an intermediate density lipoprotein, and then eventually an LDL, or low density lipoprotein. Now, the density of these packages is based upon how much fat versus how much protein is in them. So the more fat is water, will float on the top of water. it's lighter than water, so that's what makes it a low density lipoprotein. So here's LDL. LDL primarily carries cholesterol, and we're going to show you another depiction of this. And then HDL. HDL brings cholesterol back to the liver, does many other things, which we'll talk about later on. So here's a depiction of the chylomicron on the left side, and you can see that top part. I don't know whether you can see the color well, but the top part, 80 to 90%, that's fat. And that's being pulled out of the intestine and being put into the lymph system. The next one over is a very low density lipoprotein. It has mainly fat too, 55 to 65%. You move over to LDL, 10% fat, 45% cholesterol. And then the HDL is far right, and that has primarily cholesterol returned to the liver. So what is this circulation? Well, before we do that, this is what a low-density lipoprotein looks like. It has a bipolar membrane on the outside, and it has proteins, apolipoproteins, and you can see the top one there. That's an apolipoprotein B48. It has an APOC and an APOE. Inside of the shell is triglycerides, cholesterol in the form of esters, and free cholesterol. Here's an HDL. It has apolipoprotein A1, so it has the A's in there. It has primarily cholesterol going back into the liver. So the apolipoproteins bind the lipids and cholesterol, and they are classified ApoA through H. ApoA is found in HDL, and ApoB in chylomicrons, low density lipoproteins, very low density lipoproteins are the Bs. There are subclasses of all of these, which we're not going to cover too much. So what purpose do they serve? Basically, the apolipoproteins on the outside surfaces of the cell allow the cells of the body to bind to that particular particle, and actually in some cases ingest it, or at least digest the lipoproteins and pull them into the cells. They activate the enzymes for that process of metabolizing lipoproteins. They also increase the structural integrity, so it's strong enough to go through. So we use those as markers for, do we have high LDL? So what we look at is apolipoprotein B1. It actually is a better indicator of risk for heart attacks than cholesterol is, and also LDL. Apolipoprotein A1 is in HDLs, and we look at the ratio of those two in blood testing. So the higher the ratio, the more chance of myocardial infarction. So when you look at your lab test, you can look at those as markers. So how does the circulation of these lipids occur? What happens? Well, if you look closely at the slide, the top left is the intestine, the stomach, and the food particles coming down, and they form little mycelia, which are droplets of fat. Those are broken down in the intestine and then reformed into triglycerides, and you can see them being made into chylomicrons. That's the blue going up the little green pathway. And I'll put the, whoops, do that. If I can put the cursor right there. So that's it. It goes into the lymph system, then goes into the blood supply. The chylomicrons lose some of their fat, but it eventually ends up in the liver and then comes down out of the liver as a very low density lipoprotein, goes back into the blood supply, and is later stripped of all those things and eventually becomes an LDL. And that's the process. There is also an enterohepatic process where the body actually reabsorbs the cholesterol. and triglycerides, but primarily cholesterol. So if you look at the left, if you're going to try to diminish the amount or decrease the amount of LDL, what the medical approach to it is statins. The statin drug blocks the HMG-CoA production of cholesterol. So it blocks that enzyme and prevents the body from making cholesterol. Turns out that you get more cholesterol by making it than what you're eating, and there's not a great correlation because the amount of cholesterol that you ingest with what you have in your bloodstream. I eat 2 eggs every day. That's basically 400 grams of cholesterol, and my cholesterol stays fine. It's because the body has a way of getting rid of it. So the cholesterol is made into VLDL. We went through that, but if you look to the right, it goes back. All right, and it goes back through the hepatic portal vessels. So one way you can decrease cholesterol in the body is to, number one, block the production of it. You can do that with a statin. I prefer not to do that. I would rather do things naturally. And there's another way of blocking the reabsorption of that cholesterol, which can account for 20% of the cholesterol coming back in. And there are products that we'll talk about that will actually block that reabsorption. One of the ways the body also gets rid of cholesterol is through bile salts. And bile salts are cholesterol salts, and they're released into the intestine, and they're lost. And if they're not reabsorbed, they're going to go out through the feces. And if you block the reabsorption of the cholesterol going through the hepatic portal vein, you then lose that amount of cholesterol. It can be up to 20%. So it can be a significant amount. And we'll talk about a product called Cardiofend that has phytosterols that will literally block that. So let's talk about atherosclerosis. The beginning of atherosclerosis is actually epithelial dysfunction. And this is what happened with the children having fatty streaks in their aorta at such an early age. Before they even had those fatty streaks, they had epithelial dysfunction. What is the epithelium? It's the lining of the arteries. It's a single cell lining. It's the epithelium. And when it dysfunctions for various reasons, and the cardiac risk factors are what cause the endothelial dysfunctioning, it is intimately involved with the process of atherosclerosis. So we'll talk more about that. But as the damage occurs, if you look you'll see a green LPL, and you see a very low density lipoprotein going to a low density protein. This is on the bottom, the left-hand side. That penetrates, that's LDL. It's broken down by lipoprotein lipase. It goes in through the damaged endothelial layer and goes into the space between the smooth muscle, which is the very bottom thing that you can see there, and that subendothelial space. When it gets in there, it's not supposed to be in there. When it gets in there, the body will oxidize it. So cholesterol as LDL is not dangerous, but cholesterol, when it's acted upon by reactive oxygen species from macrophage, you can see a macrophage on the bottom, enzymes from the damaged endothelium will cause oxidation. So if you look on the bottom, there is an oxidized LDL. And what that does, oxidized LDL blocks another chemical inside the body, which is going to be critical to endothelial function, which is called nitric oxide. So when LDL gets oxidized, it decreases the nitric oxide. Well, nitric oxide is one of the things that actually decreases LDL oxidation in the first place. So once it oxidizes enough, you get less nitric oxide. Those oxidized LDL particles are absorbed by macrophages. The macrophages take them in, and when they do, that macrophage will release chemicals like tumor necrosis factor alpha and ILB. These are inflammatory processes which will affect the epithelial membrane and will also recruit more monocytes. As you can see in the top center there, monocytes are coming through the lining and joining the other ones to absorb the oxidized LDL. So that macrophage that has the oxidized LDL sends out chemicals that actually enhance the process, causes more monocytes to come. The monocyte becomes macrophages. There is more and more absorption of the oxidized LDL. The other thing that happens is that chemicals, cytokines, are produced that will stimulate and proliferate the smooth muscle cells in the arterial wall. Those will actually migrate to the top right. You see them. The smooth muscle cells migrate there. And as the macrophage becomes more and more full with oxidized LDL, it forms what's called a foam cell, and that also migrates this area where the proliferated smooth muscle cells are and fibrocytes, and forms the atherosclerotic plaque. So that's the process that goes on inside. Now, it's interesting that nitric oxide and also HDL, which we're going to show you in a minute, blocks this. So to have healthy arteries, it's important to have nitric oxide. It's also important to have HDL. Well, what happens also with this plaque is it has a cap on it, a fibrous cap. And in the initial times when the plaque is being formed, it's very fragile. It's not and can be broken, and that happens in part because there are T cells inside the lining that release chemicals that actually weaken it. So as a clot or as a plaque has been there for a long period of time and is calcified, it's pretty strong, but the younger ones can actually rupture. And the thrombus that you see depicted there is a rupture of that particular plaque. So the plaque is not a problem. It's not going to totally occlude the blood vessel. What the problem is if the plaque ruptures and becomes weak and then forms a thrombus, which then can form, you can then have emboli as a result of that. So the danger is a fragile plaque in the arterial wall. So here's a depiction of HDL, and we're going to basically look at all those things I just talked about, and we think of HDL as doing one thing, bringing cholesterol back to the liver. Well, it does a whole bunch of other things. If we're going to go top left, HDL blocks the monocyte from attaching to the epithelium and to come in and form a macrophage. If you go down in the bottom left, you see LDL becoming oxidated LDL. HDL blocks that. HDL blocks the oxidized LDL from the chemicals being released to further damage the epithelial lining. HDL blocks the foam cell from producing the chemicals that cause the smooth muscles to migrate and to proliferate. HDL blocks on the top right the factor X in blood clotting from becoming active. And the final thing is it stimulates or activates protein C and protein S, which are anti-clotting, and it blocks the platelet adhesions to each other. So HDL does a number of things. That's why it's so important for HDL to be in its proper level. And so we're gonna move on. We're gonna talk about Cardiofend. Cardiofend works on this atherosclerotic process in a number of different ways. It has microactive CoQ10, which we'll talk about, phytosterols, resveratrol in the form of Resvita, and Arjuna bark. That's what Cardiofend has. For actions, it lowers blood pressure. If you lower blood pressure, what happens? We'll talk a little bit more about this later, but when you lower blood pressure, you lower the chances of heart attacks, strokes, and all of the other things that come with that. It lowers cholesterol, and we'll show you how that, and that's because of the reabsorption of the cholesterol through the enterohepatic system. It promotes arterial health, okay, endothelial health in particular, and it reduces symptoms of angina. So that's what Cardiofend does. How does it do it? Well, it lowers blood pressure. Clinical studies have shown that 100 milligrams of CoQ10 daily will reduce blood pressure by 10% against placebo. And that's important. We're going to see how 10%, what does that translate into heart deaths and heart disease? We'll talk about that later. Statins, on the other hand, deplete CoQ10. Now, CoQ10 is found in the mitochondria. It's one of the things that is in the mitochondria to make energy. So energy is needed by all cells, and there are mitochondria in all cells, and CoQ10 is one of the little guys in the chain that moves electrons and hydrogens along a grid, a pathway to form ATP. So you need CoQ10. So decreasing CoQ10 creates a diminished amount of energy in the cell. Where do you need that the most? Your heart, your muscles, also your brain. Statins block CoQ10 by blocking the production of what we said. CoQ10, if you follow the pathway down to cholesterol, there's a side chain that comes off, and that's where CoQ10 is produced. Well, if you stop it above and you break the chain, you will not be producing the CoQ10. End result, cramping, pain, even rhabdomyosis, which is a fatal, possibly fatal disease as a result of the lack of energy in the muscle cells. So Cardiofend features microactive CoQ10, which is 3 times absorbed better than regular CoQ10. And the interesting thing is, it doubles CoQ10 levels in 100% of the users. Now, we have another product that is just CoQ10, which we'll talk about. But basically, not all CoQ10 is absorbed equally by people. And there's no real way of knowing how well you're going to absorb the CoQ10. In this microactive CoQ10, which is what a quality of life uses, you're going to find that all of the users get the same 100% assimilation and utilization across the board. Phytosterols are chemicals that look like basically cholesterol. They're a sterol molecule which can fool the enterohepatic system into thinking it's cholesterol. So if you put this in the body, it can go to the liver rather than cholesterol, and the cholesterol will go out in the feces. A great way of reducing cholesterol without having the danger of a statin reducing CoQ10. Double-blind studies have shown that phytosterols are effective in lowering cholesterol. Cardiofend has 2 grams of phytosterol per serving. The average other product made by other companies usually have about 1 gram, according to the 20 meta-analysis studies. So promotes arterial health. So Cardiofend has resveratrol. Resveratrol is a polyphenol antioxidant. We know about it from red wine. It is a trans resveratrol, which is a bioidentical resveratrol to red wine. It is found to, in 30 milligrams, to increase flow-mediated dilation, which is a gauge of endothelial function, is important in developing atherosclerosis. I told you that, that the endothelium is really the first step in atherosclerosis. Now, you can look at the endothelium, you can actually cause a flow meter, put it on there to determine the increased size of the blood vessel when you put it through a stress or a shearing force. And it does this, resveratrol increases it 62% compared to placebo. So this is a very important thing. We'll talk a little bit more about it in a minute. And the last part of Cardiofend is Arjuna bark, which has been used for years in India for treating heart problems. Basically, what it can do is reduce angina, which is a decreased blood supply in the coronary vessels. Second product is Unisorb CoQ10. And this is a straight CoQ10. I've already talked about it's a key player in energy production. It's an antioxidant. It helps prevent oxidation of LDL and also the mitochondria DNA. One of the highest places for oxidation is within the mitochondria as it's making ATP. Without CoQ10, the mitochondria can become damaged, and that will cause the cells not to function correctly. CoQ10, as we said, lowers blood pressure. It reduces severity of symptoms in congestive heart failure, and it lessens heart-related problems with heart attack and improves cardiac function and cardiomyopathy. The statin drug I've already talked about, it decreases CoQ10, therefore the muscle aches, and CoQ10 is a problem in absorption. It is not well absorbed. Matter of fact, 1% is absorbed in a crystalline form. So you have to get it in a form, and they talk about all these different, you know, this is ubiquinone and ubiquinol and all of that. You want the absorption, so they have an enhanced bioavailability. They hook it to a fat, or they put it in a fat so it's absorbed better. That's called the enhanced bioavailability CoQ10. The thing is, the problem is, how do you know if you're one of the good absorbers? So what quality of life has is a cyclodextrin, which actually, if you look at this, CoQ10 is sticking in this little funnel. And the funnel, what it does is makes CoQ10 water soluble. So it becomes hydrophilic instead of hydrophobic, and can be absorbed better and is released slowly as a result of that. So microactive CoQ10 doubles CoQ10 levels from baseline in 3 weeks. It delivers a sustained release for over 24 hours. Typically, CoQ10 will go up for about 2 hours and then drop down. So if you're not taking divided doses, you're not going to get it. This is why I take this CoQ10, because I like to have 24-hour protection. It is 3 times better absorbed than standard CoQ10 and 2 times better than solubilized. The CoQ10 is important. Next thing is triglycerides. They were going along in the chylomicron, remember? Triglycerides, triglyceride. This is a triglyceride. Look at the top left there, there's the glycerol molecule, and it has 3 fatty acids attached to it. And those fatty acids make it a triglyceride. So it's a glyceride with 3 fatty acids. So there's different kinds of fatty acids. Some of them are saturated, some of them are unsaturated. Saturated just means that there is no double bonds in the fatty acid. These fats are usually animal fats, except for palm oil, avocado oil, coconut oil. By the way, I like coconut oil. I cook my eggs in coconut oil. I guess the cholesterol goes in with the omega-3 fatty acids. So that helps all of the processing. Saturated fats are solid at room temperature. Unsaturated fats are not. They have an unsaturated bond, which causes them to not be straight like a saturated fat. They're kinked, and so therefore they're more flexible. Unsaturates, olive oil, peanut oil, and canola oil. The regular polyunsaturates are vegetable oils, and somewhat avocado. So fats basically are a combination, either saturated or unsaturated. And the unsaturated ones are defined by where the first double bond of the molecule occurs. So there's two ends to a fatty acid. There's a carboxyl end, which is on the right side, and then there's the omega end on the left side, as the depiction shows. In the top one, the ninth carbon, between the ninth and 10th carbon, there's a double bond. So that makes that fatty acid an omega-9 fatty acid. The one below is an omega-6, and the one below that is an omega-3. They all have different properties. And when we look at the omega-3, we see with this one, we just see one double bond at number 3. You can have multiple double bonds. And so this is an omega-3 fatty acid, it's alpha-linolenic acid. So when we look at essential fatty acids, these are fatty acids that your body cannot make. They have to be eaten. There is an omega-6, which has on the 6th carbon, and that process that's on the left side, it goes down and it forms PG1s, PG2s, and leukotrienes. The PG2s and the leukotrienes are pro-inflammatory and pro-blood clotting. So they're not very good for us. Okay, so we do not want to eat a lot of omega-6s. The ratio should be much more omega-3 to omega-6, or at least 1-to-1. The omega-3s and the omega-6s, by the way, are vegetable oils. Omega-3 is flaxseed, and that's alpha-linolenic acid, which is the one up on the top. The ones we really want are EPA and DHA, which are down on the bottom. They're 22 and 20 carbon compared to 18 carbon for alpha-linolenic acid. So if you think, well, I'm getting my omega-3 because I'm eating flaxseed, basically 5% of alpha-linolenic acid will be made into EPA or DHA. So you're not getting what you really need to do the cardiovascular help that you're looking for. And if you have more omega-6s in your diet, it will actually block the alpha-linolenic acid from becoming EPA and DHA. So it behooves you to have a source of omega-3 fatty acids. Now they are anti-blood clotting and anti-inflammatory. So here's what I just said, anti-inflammatory. You want to be a 1-to-1 ratio. I tell people say, well, which one is the bad one, omega-6 or omega-3? Tell them, just remember 666 is the bad guy. We'll move on. So what does EPA DHA do? The benefits are anti-inflammatory. And well, there's another slide that does more of this. This talks about the research where it was discovered. In the early 70s, they found that people in the United States were dying, 64 men, 46 to 64, 40% deaths were heart disease. And in Greenland, the males were dying with 5% from heart disease. So some Danish researchers went and figured out that it was the omega-3 in their diet. They were eating blubber, which had omega-3s in it, and the end result was it helped them. So they figured out that's where it came from. So what does it do? It reduces triglycerides by 25 to 30%. in hyperlipidemic patients. It drops blood pressure, mild drop in blood pressure. That's important in cardiovascular disease. It decreases the frequency of arrhythmia. It decreases the risk of sudden death in a big study of nurses in Europe. It decreases inflammation. It slows down the buildup of atherosclerotic plaques, and it reduces stroke. So do I take omega-3 fatty acids? Yes. Quality of life has an omega PL, which is Neptune Krill Oil. It's an omega-3 with EPA and DHA. It also has phospholipids and astaxanthin, which is an antioxidant. Krill is zooplankton. It inhabits the Arctic Ocean. It contains EPA and DHA bonded to phospholipids, not triglycerides. Fish oil is bonded to triglycerides. Phospholipids pass through the membrane much easier because cell membranes are phospholipids. So it can actually just go right through much easier. It's better absorbed. Now, where did the fish, we eat fish, and where did they get the omega-3s? You know, they get salmon, it has omega-3s. Where did the fish get the omega-3s? Does it make it? The answer is no. Algae makes it. And these zooplankton and fish actually eat the algae and get the omega-3 from the algae. So a lot of times we think, oh, the fish is really good. Well, it's actually somebody else is doing the job. So what happens? What's the advantage over fish oil? Better absorption, 91% compared to 65%. Better efficiency in reducing cholesterol and triglycerides. We'll look at a study about that. And has antioxidants, all right, which is astaxanthin, 48 times greater. So looking at a comparison of Neptune Krill Oil with 1 gram of Neptune Krill Oil with patients with hyperlipidemia, you have cholesterol reduction 13%, LDL 32%, increase in HDL 43%, amazing. Reduces triglyceride levels 11%. This was much more significant than fish oil. So I talked about endothelial dysfunction. The endothelium regulates homeostasis by controlling vasodilation and vasoconstriction. It also, endothelium suppresses smooth muscle growth and migration, which we talked about, forming the plaque, and it inhibits inflammatory processes in the inner artery. So vasodilation is the balance between vasoconstrictors and vasodilators. Nitric oxide is the big factor in this. Nitric oxide is produced by endothelial nitric oxide synthase from arginine. And endothelium also releases prostacyclin and bradykinin, which are also dilators. They actually also increase nitric oxide. And all of these decrease platelet aggregation, which causes clotting. Vasoconstriction is done by endothelin, which is produced in the arteries, and angiotensin. The smooth muscle proliferation is and pro-oxidation occurs with vasoconstriction. Activation of macrophages in smooth muscle found in plaque is increased by endothelin. So we don't want the endothelin because it is pushing towards atherosclerosis. Here's nitric oxide. When it has shearing forces, which is on the top, it stimulates the nitric oxide to form NO, which is nitric oxide. This is endothelial nitric oxide synthase. And that nitric oxide goes into the smooth muscle and causes relaxation. So it increases the size of the blood vessel. The nitric oxide inhibits what we just talked about, endothelin, angiotensin, which we're going to talk about too, which is a vasoconstrictor, inhibits platelet adhesions and aggregation, inhibits leukocyte adhesions, where it attaches, the monocyte attaches and then comes in and becomes a macrophage. It inhibits smooth muscle proliferation and inhibits LDL oxidation. So we like to have a lot of that stuff. So Metasol is a product that increases nitric oxide. So low molecular weight polyphenol comes from a process of processing lychee fruit and attaching it to a green tea extract. And it's a flavanol, which is found in green tea and chocolate and wine. And flavanols do what? Number one, they increase nitric oxide, which then increases what? Possible benefit, improved blood flow, decreased blood pressure, and prevents platelet aggregation. Flavanols also reduce LDL oxidation, which we know what that does, and they also inhibit inflammatory enzymes, which also increase atherosclerosis. So what they've been able to do is take a high molecular weight flavonoid and break it down from like 500,000 Daltons to 5,000. So it's readily absorbed much better than the original lychee fruit. And it has a number of great effects. It reduces oxidative stress. It will, in male smokers, decrease platelet activity. It reduces inflammatory markers in young people. It is also, I like it, I take it twice a day because it gives me stamina. Get a little older, you need more stamina. That way I can keep up with my 40 and 50, or well, not quite 50, but pretty soon, son on the ski slopes. The last product is Presiquel. So we talked about blood pressure being a risk factor for cardiovascular disease, and it damages the endothelium. There is a constituent or constituents of casein, which is the milk protein, 2 tripeptides, both of which are, one is valine, proline, and isoleucine, proline. These two in conjunction actually, which are naturally in milk, act as a blood pressure medication. And I shouldn't really call it a medication, but they inhibit ACE, which we'll talk about in just a second, which then promotes blood flow. So the body regulates blood pressure with something called the renin-angiotensin-aldosterone system. And if you look up on the top left, so kidneys are stimulated by the sympathetic nervous system. If you're being chased by a bear, your blood pressure goes up. And so that's stimulation. If you have hypotension, the body recognizes that in the kidney, and it says, okay, we need to have more fluid, therefore we're going to cause absorption of sodium. Or if you have a decrease in sodium, the kidneys put out something called renin. Renin is an enzyme that causes angiotensin to be broken down, angiotensinogen to be broken down to angiotensin 1. And then with the ACE, it's angiotensin converting enzyme. It produces angiotensin 2. And angiotensin 2 goes to the adrenal gland, top right, produces aldosterone, which causes you to reabsorb sodium and water, which increases your blood pressure. Angiotensin 2 also stimulates the pituitary to release antidiuretic hormone, which then causes sodium retention. Angiotensin itself causes sodium retention. Angiotensin 2, it causes thirst. So the more fluid you have in a closed system, the higher the pressure. So that's why the increase in fluid will increase the blood pressure. It causes systemic vasoconstriction. It is one of the vasoconstrictors. And it also causes hypertrophy of the heart and cardiac muscles. So that's the system. The ACE part of it that you see there is what this milk protein does, or not protein, but tripeptides. So the way the medical profession decreases blood pressure is use diuretics to decrease sodium, therefore more fluids go out. Beta blockers decrease the heart rate and the force of the beat, decreases blood pressure. ACE inhibitors blocks the conversion of angiotensin 1 to angiotensin 2. Angiotensin receptor blockers block angiotensin from stimulating the contraction. And then calcium channel blockers prevents calcium from entering the heart and blood cells, which causes contraction. Better to do it naturally. Why do we care? 1/3 of Americans are hypertensive. 30% are prehypertensive. Prehypertensive is 120 to 139 systolic. Diastolic 80 to 89. Hypertension is 140 over 90. Okay, so that's why. So who cares? Well, for every 10 to 12 points you decrease the systolic, and every 5 to 6 points diastolic pressure, this is what happens. There's a 35% reduction in strokes. There is 35 to 40%. A 20 to 25% reduction in coronary heart disease, 45 to 55% reduction in congestive heart failure, and a 20 to 25% reduction in cardiovascular disease. So it's important to have even that small an amount in decrease in blood pressure, huge effects down the road. Presiquel is a proprietary enzymatic process that takes these tripeptides and preserves them. They also go into the digestive system and are not degraded, which is very interesting. They get into the body intact, cause no significant change in blood chemistry, urinalysis, through multiple human studies. Because they're a milk product, you think, well, maybe lactose is involved. Lactose, there's less than 0.0%, so it does not stimulate any digestive issues with lactose. So it's a great product, and it's also called a meal BP, and it won the 2013 Best Supplement Award from the Better Nutrition magazine in heart and circulatory category. So that's a meal peptide. We use it with patients that are, you don't use it instead of a blood pressure, use it in patients that have high normal blood pressure. They're the prehypertensive ones, and to lower that down, that's what I use it for. It works great, don't have any side effects, and it's just a really great product. So that's our program for this evening.
Thank you, Dr. Sunshine. We're now going to begin answering some questions that were submitted today, one in particular that we got. It's from Dr. Schur, and he asks, as a targeted approach, can you combine these formulas together to form a kind of protocol, and is there any complications with that?
Number one, you should combine them. Cardiofend is a combination. It is a number of different things, but yes, you can combine them. As a matter of fact, I take several of them myself to improve the vascularity and improve stamina, and it's just they're very good. So no, there is no contraindications to combining them, and there's no set protocol to do that.
Okay. Thank you, Dr. Sunshine. And I want to thank everyone for attending today's webinar, Natural Approaches to Cardiovascular Health. You'll be able to view this webinar. So if there's anything that Dr. Sunshine went over very quickly that you just weren't sure of or want to go back and listen to later, we'll have it on demand. And others like it are also on our website, QOLLabs.com. If you click on the tab called Education. And if you haven't been on our newsletter, we also will be sending a link out in an email, which will also include the presentation and Dr. Sunshine's PDF, which is his whole presentation, so that you can actually look into each slide personally to see what the information is. And that should be coming in the next couple days. If you have any other questions, please reach out to info@QOLLabs.com. And on behalf of QOL Labs and our presenter, Dr. Barry Sunshine, I want to say thank you for joining us, and have a great rest of your day.